Can everybody hear me okay? Yeah, wave in the back if I can't for some reason. So my name's Anita Licata, and I'm a dermatologist with 4 Seasons Dermatology. Some of you may know me. I've been around for decades. So today we're going to just go through some things that I think we all see in clinic. At least I do a lot, so I figure you must as well. And I'm just going to kind of start with a standard patient and go through maybe some of the questions and concerns that they would have and give you kind of both the long answers and the short answers. So I'll try to give you a lot of information, and then I'll try to also distill it into an easier 15-minute visit kind of thing. So this is the type of person that maybe I would see on a regular basis. Someone who may have spots on their skin. They may have been out in the sun for many years, decades even, so they wonder what all these spots are. They're worried about having skin cancer. You might start to talk to them about sun protection. They tell you they're worried about all the toxic ingredients in sunscreens. They're worried that they might not get enough vitamin D if they wear sunscreen. So they have all these concerns. So let's go through and see what there is to say about them, and then see where we feel at the end. So first of all, what are all these spots? Well, probably most of them are what we call lentigines, or Lentigo for a single. People used to call them liver spots back in the day. They are large, freckle-like spots would you have that appear decades after you've had the sun exposure. Shoulders, face, hands, and they are just increased melanin. So this would be what it would look like on pathology. No increased melanocytes, but just increased melanin granules. That's different than melanoma, okay? And that's what we do worry when you look at all these brown spots. You're like, could there be a melanoma in there? So there is a form of melanoma on heavily sun-damaged skin called Lentigo maligna melanoma. As opposed to just being increased pigment, there are increased numbers of melanocytes. Clinically, what would make you think, oh, this is something that's a little more concerning, is that it maybe has more than one color, larger, looks like somebody sprinkled pepper in it. So not just like regular coffee-colored spots, but same thing, the ABCDs that we're going to talk about for melanoma in general. So again, these are induced by the sun. They are a marker that you've had significant sun damage in the past. They appear decades after the exposure. They are induced primarily by UVA wavelength of sunlight. That's actually the light wavelength that you would get through tanning beds, or if you're tanning through windows, if you're driving. That's why we often see people having more of them on the left side, at least in this country. If you're in England, it would be the other way around. When you get more sun, these get even darker. So they'll be more prominent in the summer, fade a little bit in the winter. And here's some people on spring break that are working on their lentigines. You will not see them for a couple decades later. They look great now. This is a patient of mine who is taking her arm. She's in her 70s, and it's holding it against the abdomen. So this is what skin looks like as we get older. Here, okay, it gets a little looser, maybe. Here is all from the sun. So what we usually think about of aging changes with the skin is really from sun. And, oh, you know what? I think I started early, as I realize, well, yeah, I guess I'm just noticing now. I guess the talk wasn't supposed to start till 1:15. A little louder. So the question is, I think I'm realizing that the talk wasn't supposed to start till 1:15, and we might be having a few more people that are, or what is
Yeah, the schedule says 1:15. That's my
okay.
as well. So,
yeah. For I wonder if we should just wait a minute or two to see if.
We wait a minute
Okay. All right. Got it. Okay. All right. So I'm not good at telling jokes, but I'll kill time for a couple of minutes. I can take any questions so far. Yes. Yeah, so the question is, if someone has had a basal and or a squamous cell carcinoma, are they more likely to develop melanoma? And the answer is yes. It's not a huge increased risk, but it is higher than someone who's never had skin cancer. So having had any type of skin cancer, you're at increased risk. Having had one melanoma, you're at increased risk for having a second one. Interestingly, if you have any type of cancer, you're at slightly increased risk of getting other types of cancers. And probably that has to do with some host effects, such as your particular genetic makeup, the way your immune cells work. So we see that across the board for all different ones. So I'll catch the people who came in late up to date. I won't go back and say everything I said. That would be boring. But so I'm just going to talk about a normal patient that I might see or that you might see in primary care who has questions about spots on their skin, sun exposure. They may also be concerned about sunscreens, vitamin D. These are questions I see every day. So I'm going to go through how I would approach this, give you a lot of information, and then also distill it down to hopefully a smaller amount of information. So again, we're just going to use this standard patient, and I think I'm okay because it's 1:15 now. All right. These would be the questions she would have. I'm concerned about having these spots on my skin. I'm worried about having skin cancer. And I'm also worried about potentially toxic ingredients in sunscreens, and I'm worried about low vitamin D. So we're kind of going through, well, what are these spots? The brown spots are called lentigines. You get them from, many years of being out in the sun. And we're just sort of saying that this is how the skin ages normally, and this is how the skin ages from the sun. So the sun is what causes brown spots, wrinkles, all those changes are from sun. So when people say, oh, my skin's just getting old, it's really from the sun. I bring this up because this is something you probably see in your clinics a lot. People are very worried about this bruising, and it's not because they have low platelets. I mean, very rarely they might, but usually this is in older people who it's from the shirt sleeves down that they get spontaneous bleeding. So you get these purple patches, and sometimes they'll leave pigmentation as well. And what's happened is that over the decades of sun exposure, you've lost the elastic tissue around the blood vessels, so they spontaneously rupture. So that's why you're only seeing it in the heavily sun-damaged skin, like back of the hands, back of the arms. You're not seeing it like on the chest or abdomen. This is a biopsy from, imagine that woman that I showed you. This is a mid-70-year-old person. This is a biopsy from buttock skin, and this is biopsy from the arm. So what you're going to notice is in intrinsically aged skin, or just skin that happens as we get older as opposed to being out in the sun, it looks fairly normal. This is the epidermis, and with these very nice reedy ridges that are holding on tightly to this very nice connective tissue at the base. This is their arm, okay? And we notice a couple of things. One is the reedy ridges are gone, okay? So it can't hold on very well, and that's why it tears very easily. And this nice, what had been kind of a thick, rubbery connective tissue has turned into like crumbled styrofoam. So that's not providing any support for the blood vessels. So this is histologically what happens to the skin after many decades of sun exposure. And sunlight contains many wavelengths, from visible, UVA, UVB, hopefully no UVC. The different wavelengths penetrate to different depths. The higher energy have shorter wavelengths, as everybody remembers from physics. So that would be UVB. It has a lot of energy, but it doesn't penetrate very deeply, causes sunburn. UVA, a longer wavelength, penetrates more deeply, but doesn't contain as much energy. But this is getting down into the collagen. Okay, so a lot of the aging, as we mentioned, and the brown spots, again, is coming from this UVA wavelength. So just to look at it another way, here is sunlight, and this is our cloud cover. We have ozone and the regular atmosphere. The long wavelengths are the visible, like red, to blue. And then getting shorter, UVA, UVB, and UVC. UVC is a really short wavelength. It's basically biocidal That's what, in fact, they'll use like in labs to disinfect hoods. So our ozone, at least now, thank you very much, is blocking UVC. If it didn't, we'd be in huge trouble. We'd all be in a lot of trouble. But sunlight blocks some of UVB, some of UVA, and very little of visible. I mean, cloud cover blocks that. So again, these are the wavelengths that are in natural sunlight. UVB is the one that burns you, and it causes immediate DNA damage. Those signals, damaged DNA, is what actually induces the skin to tan. So that tan then helps protect from further UV damage. If you get a lot of UV, again, primarily B exposure, you will sunburn. And when people sunburn, they tend to get out of the sun and not, and avoid it further. So again, here's an example of your melanocyte. This is the pigment cell that's sitting at the base of the epidermis, and it has these little dendritic arms that transfers pigment granules to the keratinocytes, and that's what gives us our color. Everybody in the world, depending whether you have really fair skin or really dark skin, has the exact same number of melanocytes. So they have the exact same number of cells. They just make more or less melanin granules. People who tan really easily and darkly will produce more granules. People who don't tan very well, not as many. The ultraviolet light stimulates the granule production. The keratinocytes pick up the granules from the melanocytes, and they kind of like put it on over their nucleus as a little hat. Okay, so you can think about it like, the sun comes down, they put up this umbrella to protect the nucleus from further damage. And this is actually what's happening. Here's your DNA. The ultraviolet light, again, primarily B, causes many types of DNA disorders, but one is particularly this thymidine dimer. So these two base pairs will bond together, which obviously we know is not supposed to happen, and then all these repair enzymes come in to slice out that piece of damaged DNA. And everybody in med school had to learn all those different pathways. This little piece then that's taken away, that serves as a molecular trigger to cause melanocyte to produce melanosomes. So you actually have to have DNA breakage and repair before you'll tan. So if people say, well, tanning can't be bad. Well, it's interesting that the signal for tanning is DNA damage. Now, our body can certainly, it's dealing, right as we're sitting right now, it's, identifying repair and repairing, damage all the time. So this happens, okay? If you have too much of an insult, though, the repair, like the road crew, can't keep up with the damage, and you're going to have permanent, DNA mismatches, et cetera, that then will predispose you to cancer and other things. Okay, so again, we talked about UVB causing these dimers. UVA, interesting, UVA wavelength. It primarily just causes existing melanosomes, the pigment granules that you have, to oxidize. So people who go to a tanning bed will come out looking bronzy. Sometimes it's kind of an orangey color. And it's not because you've stimulated new melanosomes, but because you've taken existing ones and they've turned color. So you don't really get much of a protection from a UVA or a tanning bed tan. All right? Sunburn is when the incoming damage exceeds the ability of the body to repair it. And cells, when they decide they've had too much DNA damage, they say, okay, I'm done, and they undergo what's called apoptosis. They say, you know what, it's too much, I'm dead. They put these signals on them, on their surface. Immune cells come in and take them out, and that's what causes a sunburn. So you've definitely overwhelmed your body's ability to even try to repair the damage. So again, to summarize, we talked about the UV exposure causing the DNA breaks. That is the trigger to tan, which should hopefully then protect ongoing injury. There's a lot of host factors that go on here. Some people genetically have better or worse repair enzymes, et cetera, et cetera. So that's why some people are more prone to getting skin cancer and other types of skin cancer as well because of host factors. And we talked about if there's the, overwhelming injury, the cells will completely die. So what can you do to prevent ultraviolet light from entering the skin? Well, one is you could, have clothing, shade, etc. You could wear sunscreen. How do they work? Well, they work in two ways. There's one called physical, and that is their particulate matter, and it's either zinc or titanium, and that just causes the sun rays to bounce off the skin. Or there's a whole host of what are called chemical sunscreens. Those work by changing the wavelength of sunlight into primarily heat. Okay, so if you've ever noticed that your skin feels hotter when you're wearing sunscreen, that's probably why. Because it's changing the ultraviolet radiation into heat. So here's all the different 11 sunscreens that are currently approved by the FDA for use in the United States. And what we're looking at here is the wavelength that they have their peak absorbance, which is in blue, or their any absorbance of the wavelength of light. So you can see here zinc is at the top, and it pretty much absorbs throughout the spectrum. So zinc is really good. The other ones, it's variable. But here's the 11 ones that you might find on the active ingredients of a sunscreen product. So how do they measure SPF? You might wonder. It's called sun protection factor, and it's actually done in the lab. They take someone, and they literally irradiate their skin with and without the product in question. And they'll say, okay, at what point does it turn red, i.e. burn? And then how much longer is that with the product on than with the product off? And that gives you SPF. So if you got red at 5 minutes with no product, put the sunscreen on, and it took 40 minutes to turn red, that would be an SPF, sun protection factor, of 8. How come it doesn't seem like it works this well in real life? Well, a couple of reasons. Because when you're in the lab, they have a very standard amount that they put on, which is 2 milligrams per centimeter squared. That translates to about 1 ounce for a small person and 2 ounces for a larger person. So that's, if you have an 8-ounce bottle of sunscreen, that's a quarter of the bottle. So probably not happening that amount that you're putting on. So you're just from the get-go, getting a less of a concentration because you're putting on less. It also declines with time. It's that SPF that, first 10 minutes you put it on, but a half hour is less, 2 hours it's even less, 4 hours, who knows. Everybody's different, too. People seem to, it washes off, sweats off, wears off different on different people. Also, products may not screen all the wavelengths, as we've seen, depending what ingredients are in there. So the FDA now does define broad spectrum, okay? And this is how they assay it. Unfortunately, you can't do it in vivo. It's just really hard to get UVA consistent in vivo measurements. So what they do is they just do chromatography, and they're looking for the absorption peaks. And as long as they match a certain standard, you can say, okay, you're blocking, these peaks. But that's done, again, that's done in vivo, done in vitro, sorry, not in vivo. But that's how broad spectrum is defined. And in 2011, the FDA came up with some labeling requirements. You're not exactly seeing it right now, though, because they grandfathered it in for everything that still had an expiration date. And some things that were out in 2011 didn't have an expiration date till 2015, 16. So we are just going to start seeing products with these specific labels. And here's what the FDA is saying. Okay, that you can no longer say that something is waterproof, sweatproof, and you can't even call it sunblock, because we know it doesn't really block all the sun. It kind of screens it, okay? So it's got to be called sunscreen. It's got to be SPF of 15 or above to even call itself a sunscreen, and to have any effect against aging and or cancer protection. No longer can you say, again, waterproof. It can say water resistant, but you can either pick 40, 60 or 80 minutes, depending on the manufacturer is supposed to do some testing. Okay, so those are going to be the, and I think also they cap it at 50. So it'll say SPF 50 or 50 plus. You can't, say it's 100, it's 150. So let's see. Okay. Well, okay, so what about it? So are all the chemicals in sunscreen worse for you than tanning? Because I get this question all the time. It's like, oh, but I got all these chemicals and you're putting it on your skin, and isn't that worse than the sun? People have lots of concerns. I'll go through the ones I hear mostly. They could form free radicals. What about oxybenzone, retinol palmitate, nanoparticles, and again, vitamin D? So what about free radicals? Well, yes. If you take many chemicals in all kinds of things that we use every day and that we might eat and that we might come into contact with, and you throw them in cell cultures, you can see some free radical generation. However, intriguingly, UVA is a huge free radical generator, and it is just, orders of magnitude higher that you would see than the sunscreen ingredients themselves. So actually, this is pretty easy. Sunscreens actually will do more good than harm in preventing UVA-induced radicals. Okay, that's, if it's sunlight versus sunscreen, you get more free radicals with sunlight. How about oxybenzone? Well, that's a compound that has estrogen-like activities. It does penetrate the skin. You can measure it in urine. Don't measure it in blood all that much because it is quickly excreted, but we do find it in water, the ocean, that, and also hundreds of other things too. We can find it in our environment, including tons of antihypertensive medications, Prozac, anything that we are using, we are finding in our water. I don't know the effect of it. It is been reviewed and approved by the FDA, but if people have concerns, you can certainly find products without oxybenzone in them. In fact, one place I like to refer people to go is a website called EWG, the Environmental Working Group.org, and they look at all kinds of products, and they have a huge sunscreen section where you can look at every single product, and it breaks down by ingredient what's in it. Do they like it? Do they not like it? What are any of the concerns with any of the ingredients? So you go to the section that says the guide to the sunscreens, and you just type in the product you're looking for. They rank them from 1 to 10, 1 being their best, 10 being awful. I do like that they say here, look, before you go outside, there's other things than sunscreen, okay? You can wear sun protective clothing, plan around the sun. We're talking about not getting burned. Remember the sunglasses, find shade, bring shade. All of these are really good advice that, sunscreen is not your primary, or it's not your only tool in the toolbox. So here's a couple of sunscreens that they look at. One is, this is Blue Lizard, Australian sunscreen for the face, which gets a 2, which is good. And then you have here Neutrogena Ultra Sheer Daily, SPF 70, which they don't like so much. Okay, and why? Well, you can kind of dial into it a little bit more. This is the Neutrogena Ultra Sheer. It contains, here's some of the active ingredients. Avobenzone, that's a good UVA blocker. That doesn't seem to have any concerns. And here, 4 means kind of caution, 8 means they hate it. It's actually nice. They kind of do give the level of evidence with it as well, sort of like limited, fair. So that they're basing this on the, their opinion, their rating, at least on some amount of evidence. Here's oxybenzone. So this is why this gets a special shout out, I think, is because, websites like this identify it. There is information on the internet kind of identifying as a concern. So again, I'll let you make your own opinion, but I'm just telling you where resources are that you can look for. Here's some other ingredients. They're not liking fragrance so much. And here we see retinol palmitate, getting a particular shout out for not being happy. So if people have you heard from patients, concerned about this ingredient at all, or anybody? Is it just me? Okay. Well, good. Maybe it's kind of passed a little bit, but it was definitely out there. Sort of, things go in waves. I think there was the sodium lauryl sulfate for a while. This is one of the ones that I think is more currently on the radar. It's added, interestingly, as an anti-aging ingredient. So it's a vitamin A derivative, and it does work by making the skin smoother, which is why it has an anti-aging effect. The skin looks smoother, more cosmetic in appearance. But when the stratum corneum is smoother, it absorbs a little bit more UV light, then bounces it back. When it's dry and scaly, you kind of get like a little extra SPF protection with that. However, it is degraded with photo exposure and it becomes inactive. That's why for cosmetic reasons like Retin-A, tretinoin, there's all these anti-aging preparations you can buy at the grocery store. They'll contain retinol. You're supposed to use them at night because the retinol will become inactivated with sunlight. There was a study in 2010 in mice that did show an increased number of tumors when they were just treated with retinol palmitate versus a vehicle. Interestingly, though, they did have reduced overall lesions, so the mice looked great. So the mice were like, I'm going to keep it now. One of the concerns with this study is that it was not done in conjunction with sunscreen. They just looked at the retinol palmitate. And again, we know that UV is a huge free radical generator, so it may be that in actual use, the retinol palmitate and UV is not as bad of a combination. But in any event, the FDA did review all the data that's available on it and still, gave it an okay. So again, information, you can decide what to do with it. And when patients have questions, you can always refer them to this site, which I think, then they can make their own decisions as well. Nanoparticles, anybody hear of these? These are in the news and, as well, some people will question these. It's a technology used to make zinc and titanium more transparent. So large particles are basically finely ground, so, it goes on better, looks better. It's a process called micronization. Technically, a nanoparticle is between 1 and 100 nanometers, sometimes also called ultrafine. And the reason, obviously, people don't want to just put zinc on that looks like that. So people like, when it's not as chalky. A very few studies did seem to suggest that nanoparticles might have harmful effects, but many and larger studies, both animal and human, actually don't even find evidence that the particles cross the skin barrier. So, it's generally thought to be safe. Again, it's approved by the FDA, and even more importantly, it gets a big green light from the EWG as well. So they're not even concerned about it. Okay. So just going through the popular concerns, I think we kind of talked about free radicals, nanoparticles, and for other ingredients, any other ingredients that people bring up, I would say just, refer them to the EWG site and they can become informed and make their own decisions. But what about low vitamin D? I hear this a lot. Well, there are some in vitro and in vivo studies looking at cell culture lines that do seem to suggest that the skin will make less vitamin D when a sunscreen is present. And probably everybody remembers the vitamin D pathway. We can get it a couple of different ways. We can either ingest it orally as D2 or D3, and it's metabolized then in the liver, or the skin from cholesterol can synthesize vitamin D3 with a little bit of UV light. So, will wearing sunscreen make me deficient in vitamin D? And again, there's a little less production in the skin because of blocking the vitamin D, but it does not appear to be clinically significant. That is, it doesn't seem to change blood levels. In fact, there's many other factors that have much greater effects on vitamin D level, such as what is your skin type, how darkly are you pigmented, the amount of skin exposed, your age, where in the world are you, what day of the year, what time of the day, what's the ground surface like, the altitude, cloud coverage. It gets to be pretty complex. And vitamin D levels, this is looking at some different skin types in Auckland, New Zealand. So this is a very sunny place. you're looking here on the y-axis is what was their blood level of vitamin D measured across the year. Now, it's highest for them in their summer and lowest in the winter because of the amount of sunlight. And you remember this is New Zealand, so their seasons are flipped. So that's why July and August are basically their winter. So that's when they're going to have the least amount of sun. You can see that the New England or the New Zealand Europeans, they're going to be the fair-skinned individuals, have the highest levels. The green line is the Polynesian, and then the red is the Southeast Asian, and the last line is Indian. So from light to darker skin. The darker your skin is, the less vitamin D you have. And it varies by sunlight exposure, different times of year. It's not the only story because, intriguingly, some people who are out in the sun a lot can still have low serum vitamin D levels. Like 10% of female Hawaiian surfers assayed were low, and they were in the sun all day. And vitamin D, low levels of vitamin D is a sort of endemic problem in parts of the country where people are covered all the time, such as parts of the Middle East. And that being said, though, 20% of observant Saudi women who basically have no dietary supplement and are never in the sun have normal levels. So, hard to say. And again, we're just saying there's lots of factors, but here's a tool for you if you want. Ola Engelsen, who's from Norway, developed this tool so you can calculate how much vitamin D, if you want to generate, how much sunlight you need to generate any dose of vitamin D. This is one of 4 pages. I'm just going to show you the first page. But this is the data that you have to enter. So, not just who you are, your age and your skin type, skin type 1 through 6. You got to know your skin type. You got to know exactly where you are, the latitude, the longitude, the time of day. Then you need to know lots of things about the cloud cover. I don't even know what all these angstrom units are. And again, this goes on for about 4 pages. So there's one option. Option 2, and I sort of recommend this, is just screen your patients. Find out what their vitamin D level is. Maybe the first screening could be in the winter. Is it normal? If it's normal, guess what? You're done. Whatever you're doing is great. If it's not normal, then you can start, looking at supplementation. And so again, just to kind of remember a reminder of how the vitamin D pathway goes. You can either take it orally, okay, it can be plant-based as vitamin D2, animal-based vitamin D3, or formed in the skin with ultraviolet light from cholesterol to vitamin D3. Now, interestingly, a little bit of sunlight converts, cholesterol to the pre-vitamin D, but ongoing radiation then takes that pre-vitamin D and vitamin D and it inactivates it. So a little bit of sunlight creates vitamin D in the skin, but too much sunlight destroys vitamin D in the skin. And I think this is, again, why we're seeing, it's not a clear-cut answer. So a little bit's good, a lot isn't necessarily better. Metabolized in the liver, where it is hydroxylated to 25 dehydroxy vitamin D here, okay? And this is what is measured with the blood tests. Now, it is again hydroxylated in the kidney to 125 D, and that's actually what's active. That calciferol is the hormone, that circulates in the body really quickly, has all the effects on the bone cells, on the parathyroid gland, on the intestine. That only lasts, though, for about 15 hours. It has a very short half-life, so that's why that is not useful to be measured. This is what you want to measure. In the setting of severe, insufficient kidney function, you may have a mismatch that you could actually, not be having, the right amounts of the calciferol, but your vitamin D stores look normal. But that's another discussion. So it's really, and that's why the PTH and everything gets screwed up in bad renal disease. So again, it's this first hydroxylated one that has the longer half-life, and that's the one that you're going to see with the blood test. So what's enough? How much is enough vitamin D? This is UVM's reference range, where most people are probably sending their samples, and deficient is less than 10. Definitely you see that associated with rickets and severe bone abnormalities. Insufficiency, less than 30. Sufficiency looking to be above 30, and toxic above 100. That's kind of a generous range, and other ranges are not quite the same. There's a lot of controversy over what level actually is toxic and how much is enough. This is from Mayo, and they have much lower ranges, 20 to 50 being optimum, and worrying about toxicity at 80. This is from the U.S. Institute of Medicine. This is their current recommendations, is that basically they feel, that 20 or above is adequate. They're not sure if above 30 is any better. Endocrine Society, on the other hand, is sort of implying that, if you're below 30, not good. And then I found this online chart that's kind of interesting, Dr. Mercola, that actually you're deficient if you're less than 50, up to 70 is optimal, and I didn't know this, you can treat cancer or heart disease with higher levels. I don't think so, but so this is from the NIH, and I think, again, this kind of puts all the different ones into, averages it, that you want above 20, possibly want, above 30, and that there is a, variety of opinions, and so, I think, each practitioner needs to decide what they feel is right for their patients. So what sunscreen should I be wearing? Well, it's everybody wants to say, wear SPF 30, reapply every hour, and you're done. There's really no one-size-fits-all recommendation. It depends who you are, how easy do you burn, what are you going to be doing? Are you going to be, playing here? Are you going to be playing there? So I say we don't want you to burn, and you probably shouldn't be getting too tan. Sunscreen is one of your tools to achieve that goal. Okay, we like these tools better. Clothing, parasols. Look for shade. Do you need to be playing volleyball on the beach? Why don't you go inside? No, I don't know. Okay, just saying. So if you're burning or significantly tanning through sunscreen, it's not working. All right, that's easy as that. What do you do? Well, you could increase the SPF you're applying. You could reapply it. You could, maybe you're not, blocking the full range of the spectrum. Maybe you have a sunscreen that's not blocking UVA. Look for one with zinc in it. Wear more clothing. Okay, so I feel like we kind of addressed, hopefully, sunscreens. And, again, the answer to that question is, you don't have to come up with SPF 30. You can just say, look, we don't want you to burn. You shouldn't be tanning so much. So what about these brown spots? Okay, well, you can now talk a little bit about what they are. They're from the sun. Are they cosmetically concerning? If so, there are various cosmetic procedures that can be done, peels, lasers, etc. None of them will work, however, if you are continuing to tan. So the first question is, are you committed to, doing whatever it takes, wearing sunscreen to not get a tan on your face? If the answer to that is no, then you're done, because the only way that all these things will work is if you do that. If they're not a cosmetic issue, it's really just a discussion what these are, where they're from. Okay, and yes, they are a marker that you've had a significant amount of sun exposure, so you would be at increased risk for skin cancer. I'm worried about all the chemicals in sunscreens. Well, we have a resource, so we don't have to have a long discussion about that. How much sun do I need for vitamin D? Well, I think the easiest answer to that is let's see where you are, and then we'll talk, or you can refer them to the website if they want to do that tool to calculate that. Physics, yeah. Okay, so I'm careful now. I've always been careful. I'm careful, so I'm not going to get sunscreen. Now I'm being really good. I'm not out in the sun. I'm not going to get skin cancer, right? Well, the answer is kind of maybe. First of all, sun damage in the past can appear as skin cancer later, even if you're continuing to be good. On the other hand, with that, it's much less likely, particularly for basal and squamous cell. If you had a lot of sun damage early on, but you've been good later, then that definitely will help you out. But unfortunately, the sad thing is like not all skin cancer is sun-related. So we spent a whole lot of time on this talk talking about sun. But that's not the whole story. In fact, that's only part of the story, particularly as it comes to melanoma. So, it's important to remember that melanoma, at least half of the cases of melanoma occur in places not out in the sun. So while many types of melanoma, i.e. particularly the Lentigo maligna that we talked about, the one in heavily sun-damaged skin, is related to sun, a significant number of melanomas are not blamable on the sun. This is a diagram of where basal cell skin cancers are. The dark is where the highest percentage of, and you can see it's pretty much face, chest, back, very little, other parts of the body. So 85% of basal cell carcinoma is going to occur in sun-exposed areas. Interestingly, squamous as well, you're going to see them head, neck, and hands. For some reason, it's very rare to get basal cell on the hands, but lots of squamous cells on the hands. This is a diagram of all the melanomas that were seen in this place in Brazil, Santa Catarina, Brazil, over this 7-year period. And every dot is where there was a cancer. And you can kind of see it is sort of an interesting pattern. Here is this sun exposure, okay, with a lot of the cases on the head, but then you can see it, other places as well. Now, interestingly, with the head, you'll notice more occurring on what side? The left. So, again, that is the sun exposure, the driving on that side. Now, you're also going to see a lot on the soles of the feet. So what's, that's a little weird, right? So obviously that's now not sun. In Brazil, you have a Native and an African American population as well. Much less common for African Americans to get melanoma, about 1,000-fold less than Caucasians, but a high percentage of those tumors are seen on palms and soles. In fact, Bob Marley died from a melanoma on his toe. So, many more pieces to the story of melanoma. Slightly. You'll see slightly more on women, like on calves, and slightly more in men on back. It's not not dramatically different, but yes, a little different. Distributions on men and women. Okay, so we'll come back to melanoma in a second. We'll just review. So when we talk about skin cancer, there's melanoma, basal cell, squamous cell is the most common. That probably gets you 95% of all the skin cancers. Cases in the U.S. per year, here's melanoma, 70,000 that are invasive, 60,000 in situ, but non-melanoma, primarily BCC. So basal cell, much more common than squamous cell, about 3 million. I mean, huge numbers of basal cells and squamous cells. Should we worry? How much should we really worry about non-melanoma skin cancer? Not that many deaths from basal, a lot of disfigurement, but in some deaths. But really, the non-melanoma skin cancer that's going to be more likely to cause death is squamous cell. It's not tracked by tumor registry, so we don't have as good numbers as we have for other cancers. The estimate from the Skin Cancer Foundation is 3,000 to 8,000 deaths a year, which is not inconsequential. And if you compare that to melanoma, of deaths about 9,000, 10,000 a year. So it's getting up there at the higher end of the estimate. These numbers, I think, are probably, it's a good range because I pulled out some statistics. In the United Kingdom, they found 638 deaths in a year, and when you compare that to, if you extrapolate that to the U.S. population, you'd get the lower number, about 3,000. And then in New Zealand, if you extrapolate that for the U.S. population, you come up to about 7,000. So I think those are pretty good numbers. Somewhere between 3,000 and 8,000 people will die each year from squamous cell carcinoma. And what's the risk factors for that? Well, pretty much being fair, being older, having sun exposure early in life, having ongoing sun exposure, radiation, immunosuppression. Interestingly, transplant patients, we're seeing as people are living longer and longer that we're having a big problem with squamous cell carcinoma, particularly in transplant. And the higher the immunosuppressive dose, the more likely you are to get squamous cell. In fact, I think in cardiac transplantation, where the doses are among the highest, and in Australia, where sort of the sun is the highest, that if you make it through your first year after transplant, after a cardiac transplant, the number one leading cause of death is squamous cell carcinoma. So squamous cell is very nice. If you're a researcher, you're going to love squamous cell because it behaves really predictably in the lab. You irradiate it, you do, anything to it, it really behaves in a dose-dependent fashion. So this is like some mice. They shave the skin, they shine radiation on it, and they'll create these lesions, which look a lot like these lesions, which we see in our patients. These are the actinic keratoses. They're, scaly, crusty, red, sometimes they hurt, happening in heavy sun-damaged areas. Scalp, head, hands, and a small number will then take off and grow into squamous cell carcinoma. So it's a very linear progression. You can see it under the microscope. The first change are these abnormal squamous cells. All right, they get bigger and bigger and take up more and more of the epidermis. When they fill the epidermis, it's called a squamous cell carcinoma in situ. When it breaks through the epidermis and heads down into the dermis, it's called an invasive squamous cell. So very linear, predictable progression. So what are some factors that might distinguish a low risk from a high risk squamous cell carcinoma? Low risk tend to be small, less than 1 centimeter on the face, 2 centimeters on the body. They grow slow. They have a very well-differentiated histology, and they're not on the lips or the ears, which tend to be a higher risk area. So higher risk, grow quickly, have bad-looking histology, and here we have some examples of some very common-looking squamous cells, like these hard nodules. Here's a couple that would be more higher risk on the lip, and you can just see here a lot of induration around that extensive invasion, and these are not. So good actors, bad actors. Again, you love, very dose-dependent induction in experimental models. Now, melanoma, sadly, we do not have good animal models. Very few animals get the same kind of melanomas that we see in humans. And the induction, particularly in a UV fashion, is not linear. It seems to be like an on or off switch. We do have epidemiological studies, and we can say that similar associations, fair skin, sun exposure, tanning, frequent sunburns, family history, and the presence of multiple nevi appear to be associated. We talked a little bit about statistics. Here we have about 10,000 deaths a year. Here's some, these are the statistics that kind of make you go, whoa. It is the most frequent cancer now, diagnosed in younger women, age 25 to 29, is second only to breast in the next age group, 30 to 34, and its overall incidence is increasing faster than that of any other cancer. So here we see melanoma. It's about the 5th and 6th for men and women of all cancers diagnosed, but still, in terms of just total numbers, much below breast, lung, and colon. Okay. Vermont. Yeah, we have a bit of a problem here in Vermont. This is data from the SEER registry from 2006 to 10, where Vermont actually has the second highest incident rate of all the states. Okay, here's the U.S. average right here, this line here. And here we are in Vermont with an incidence of 28.5. Death also, so you can say, oh, well, we just have a high incident rate because we have amazing, practitioners who are diagnosing a lot. So we're finding all the cases. But we also have a death rate, which is higher than the national average. We're the 4th here from that same SEER data. This is just kind of interesting looking at the darker states have higher incidences of melanoma, the pale ones less. And you can think, what's going on? I'll say it was, before we jump to conclusions that there's something toxic in the water, et cetera, I'll just go through. Whenever you see a statistic, you always have to think a little bit about it. And I think this is one of the ones that's very illustrative. Okay, let's take Hawaii. Hawaii is the second lowest rate of death rate from melanoma, okay? Really below the national average. And that's kind of weird because it's such a sunny place, So this is the SEER data. You're looking at Hawaii. and comparing it to U.S. overall. Okay, here's the U.S. overall rate, Hawaii, very low. Now, what happens, though, if you look at just the white population in Hawaii? All right, it turns out that Hawaii is 70% non-Caucasian. And as we said, the incidence of melanoma in non-Caucasians is about 1,000-fold less than in Caucasians. Now, if you actually just look at whites, it's horrible, with about 3 times the national average, particularly in Caucasian Hawaiian men. So, and it turns out that Vermont is the whitest state we know. So, yeah. So it's not that bad, but this is interesting. This is actually off the SEER data site. It's kind of fun. If you ever want to go data mine cancer information, go to the SEER site. It's really fun. You can just pull statistics off, and then you can do it by state, by cancer, and then will direct you to places. But I thought that was kind of funny. When you go through melanoma, this comes up. It says Vermont. It's a small state with a big problem with melanoma. So it is. I think that's kind of interesting. So what are we looking for? I'm going to spend the last few minutes just talking a little bit about recognizing melanoma. ABCDs was what everybody heard, asymmetry, more than one color, irregular borders, but now we're saying that E is probably the best thing to look for, evolving. Is that a spot that is growing? You're allowed to get new moles, you're allowed to get new spots, but it shouldn't be getting bigger, bigger, bigger. All right, different types, superficial spreading, which is probably about 70–80% of melanomas. Thank goodness, because that's kind of the classic ones. But you have some of these other types that are a little harder. But the classic, okay, again, it's a spot that's growing larger, irregular borders, more than one colors. I think everybody would see that, and no one would have issues that, yes, that needs sampling. Again, here, very irregular borders. It's an ugly duckling. It doesn't look like the spots around it. And again, here you can see 2 different colors, a very funny border. It's very helpful to see when you look, if somebody goes, what do you think about this? Rather than just go, I don't know, well, sometimes it looks horrible, and you can say, yeah, that looks horrible. But a lot of times you have to say, you know what, just take your shirt off, because how does it look compared to everything else you've got? Is it the ugly duckling, or does it look like the other things? Dark, enlarging. One side definitely doesn't look like a mirror image of the other. I think these we all are pretty comfortable with. But this might be harder, again, in isolation. If you go, I don't know. So see what the rest they have. Anything that's really dark also should kind of be questionable. And the type of melanoma that is most fatal is something called nodular. And often what will happen is you'll have a superficial spreading that's been not identified for a while, and it grows a nodule within it. That's, tends to be a deep melanoma, and the prognosis is not very good. And again, here, these are, hopefully we never see these. You can have a nodular arise de novo, though, and these are the hardest. These are absolutely the hardest, because they don't follow the ABCDs, okay? And that, you just have to say, maybe it's topography isn't, it's not a complete dome-shaped, it's a little odd, and, there's something odd about it. We talked about Lentigo maligna. That is the one that is from the sun. Okay, that would be the, large, growing, that lentigo that just keeps growing bigger and bigger, or darker and darker. Here's one on the ear. Acromelanoma happens on palms or soles, often isn't pigmented. So this also presents a challenge. This was treated as a wart for many years. Well, actually for a year, I think. This was under the toenail. Obviously you'll think something's not right with this. It's going to get biopsied. You might think it's a squame. It comes back melanoma. Pigment, we're always, what do we do with the pigmented nail? If it's from trauma, it should grow out. Subungual melanoma often will bleed onto the skin around it. These are the hard ones. Is that trauma? Is that melanoma? It's okay to watch it for a few months, but if it's a subungual hematoma or hemorrhage, it should be growing out within a few months. Amelanotic, again, this rarely does it go into the pathologist with a diagnosis of rule out melanoma. It's like usually basal cell, squamous cell. There's no pigment in it at all. 5% of melanomas have no pigment. So as a review, melanoma starts with those melanocytes that we showed at the junction in the epidermis. It usually hangs out there for a while and proliferates. That's then called melanoma-in-situ when it's just in the epidermis. At some point, though, it breaks down into the dermis, and the deeper it travels, the worse it can become because your blood vessels and lymphatics are down there. So that's why they measure what's called the Breslow depth, and that's millimeters from the epidermis down. And this is just showing that the deeper the tumor, the lower the survival. Melanoma has an interesting staging system in that stage 1 and 2 are both localized to the skin. So when someone says, I have stage 2 melanoma, it's not in the lymph nodes. Everything else is, stage 1 is local, stage 2 is lymph nodes, stage 3 is distant. 1 and 2 is local, but 2 is deeper. So if it's over 1.5 millimeter, it's called a stage 2. And that is because you see on survival curves that there is a distinct difference between stage 1 and stage 2. Stage 1 melanoma, great survival. So melanoma, caught early, great. There are some other prognostic factors, interestingly. If you're older or male, you do worse. So this is just comparing, say, you take a 1.5 millimeter melanoma. If it's on the leg of a young woman, she has a 94% 5-year survival, 10-year survival. If this is on the torso of an older male, over 65, survival goes down to 70%. So we would like to focus on early detection for melanoma. Who do we want to target? Particularly older men. They have a higher death rate. All right. So if we're going to be in our practices, make your men take their shirts off. Look at their skin. And then also we'd like to focus on people who have multiple or atypical nevi. Because when we do stack up the risk factors for melanoma, again, talking about being transplant, having family history, having lots of moles is a higher risk. So those people with the many moles or the atypical nevi, and you see them. You go to auscultate their back, and you're like, yep, okay. These nevi tend to appear around puberty. They tend to be familial. About up to 5% of the population in the United States has them. About double in Australia, and intriguingly, we see about double the melanoma rate in Australia as well, possibly correlated. These are those funny-looking moles. If you just saw one of the moles, like if somebody said, "Hey, what do you think of that?" You might go, "Oh, it's horrible." But then you're like, "Ooh, you got 20 of those." So. Histologically, this is what an atypical mole looks like compared to a normal mole, where the mole cells are all nice and regular and sitting there in their little, reedy ridges. And atypical nevi, they kind of all bridge together. They can look funny. Just like they look funny clinically, they can look funny histologically. Again, these would be the people that we've all seen in our practices. And what do you do if you see a suspicious lesion? Well, one, you could refer to dermatology. Part of that reason is sometimes we could say, oh, no, you know what, that's totally fine. You don't need to do anything with that. But sometimes you might say, you know what, I'm really suspicious about this. I want to biopsy it. That's fine. Make sure you take an appropriate specimen and know who you're sending it to. Okay. And the best way is also is actually to talk to them. You should be able to talk to your pathologist and know that what they're saying you understand. Because sometimes you get these weird pathology reports back, like, atypical intraepidermal melanocytic proliferation with blah, 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 blah. And you're like, well, what is that? So I'd say call them. And these are terms that have just people have made up and have evolved over the years. So you see a suspicious mole. I think it's a very cute mole. So what do you do? Well, if you biopsy it and you get something back that is not melanocytic, so it's a seborrheic keratosis, a hemangioma, whatever, you're done. But if it's melanocytic, you really need to think about it, okay? So I'll end in the last 2 minutes with a quiz. So what do you think this is? It kind of looks like it, but it was a seborrheic keratosis. So a lot of these are, and sometimes if you're able to look at it really closely with a magnifying glass, you'll see these little tiny keratin horn cysts. So it's not everything big, black, and ugly is a melanoma. And that's why sometimes we'll look at it and we'll say, oh, nope, that's fine. So you could biopsy that. It comes back seborrheic keratosis. You're done. Benign lesion. How about this guy? Well, you know what? That was a sub-K too. I know. There are. Yeah. How about this guy? I know. Hemangioma. But, these are all things that I've biopsied too. So, I'm like, I don't know. That looks bad. Close. That is a pigmented basal cell. They can actually sometimes be black. Well, what if you see this? I mean, that doesn't look so good. It's kind of dark on one side and raised here and on the others. So let's say you do a punch biopsy. All right? And let's say that comes back as a nevus. Or a nevus with cytologic atypia or just something, or some kind of mole, some sort of melanocytic thing. Are you done? Let's say this came back as a nevus. Can you say you're fine? No. Right. Good. Excellent. Beware the partial biopsy of a pigmented lesion. Studies have actually shown that within a melanoma, you can see normal nevus, atypical nevus, lentigo, all of these other pigmented things, and they don't correlate with the clinical. So the big, thick, dark area may be normal, and the patchy little light area may be where the melanoma is. So whenever you're biopsying a suspicious pigmented lesion, try to take the whole thing. If you can't take 100% of it, take 90% of it. You can, just do a slightly bigger punch, or do a messy excision. But you want to get a majority of the lesion. Okay. And so we'll summarize by just going through our patient, and now we can, hopefully confidently answer their questions and their concerns. I'm worried about these spots. I think we can tell them what the spots are. I'm worried about skin cancer. We can identify whether they're low, medium, high risk. We can talk to them about skin cancer. I'm worried about toxic chemicals and sunscreens. We have a resource for them to go to. And I'm worried that I won't get enough vitamin D. We're just going to say, you know what, we're just going to check a level. There, you are done, and you can go see your next patient. All right, I want to thank my cat, who didn't have any sun questions when they were laying in the sun with me. Okay.